Welcome to Dental Campus. This is the module on the how-tos of 3D radiology. Today's lesson is about how to justify the use of CBCT in implant dentistry. Our learning objectives are the following. Are there guidelines for justified use of CBCT? When can cone beam CT be used and justified? And why can cone beam CT be justified in implant dentistry? Now, the very first and important document to consider is the document of the European Commission, Radiation Protection number 172, freely available and downloadable from the internet. It was composed by the CBCT project consortium and brings you all the information needed for the justification of cone beam CT for dental and maxillofacial radiology. And it has inspired many other sources. That is why, amongst others, the European Association for Osseointegration has formulated its own guidelines, which were then published in Clinical Oral Implant Research. In 2012, with a specific focus on the use of cone beam CT in implant dentistry, being complementary to the CBCT report. In this document by the EAO, we focus on the justification, and after you have decided that the CBCT is justified, we focus on the optimization, and the optimization is actually finding the proper balance between, on the one hand, radiation, and on the other hand, the needed image quality. And this is usually expressed as the ALARA principle, as low as reasonably achievable. But more than that, the document also focuses on the necessary training. One cannot use a cone beam CT or cannot diagnose a cone beam CT or plan on a cone beam CT if not having obtained the proper training. At the same time, the American Academy of Oral and Maxillofacial Radiology also published a report focusing again on the use of cone beam CT in implant dentistry. And this academy concluded that cross-sectional imaging can be used for all dental implant sites, with CBCT being the preferred method. As I stated before, once you have obtained a justification, you also need to go for optimization. And a lot of work and focus should be paid to the balance between dose on the one hand and image quality on the other hand. And there, normally, a cone beam CT should offer better optimization than a regular clinical CT, as it offers actually a good image quality while the dose remains lower than a clinical CT. This bar chart, based on a publication by Powell et al. In 2012 from the CBCT report, shows actually for various cone beams that there is actually a lower dose than the orange bar for a regular clinical CT. Yet, if you would apply a low dose protocol to this clinical CT, you can actually achieve this green bar, which is still higher than the cone beams, but yet substantially lower than the clinical CT. And this can even be further improved by using the latest multi-slice CT scans, which have a very fast speed and a good performance at a low dose. This is shown and illustrated here, where both CT and cone beam CT have comparable image quality at a reasonably similar dose. An important point to consider in cone beam CT imaging is the field of view. And the field of view is actually related to the dose. The smaller the field of view, the smaller the dose. This you can see here. For a small field of view, you have a low dose. When you raise the field of view, the dose is increased in an almost linear way. And the same applies to the larger field of views. So you always need to properly justify the use of the cone beam CT, but also justify the field of view by proper optimization. Another interesting figure is offered by this dose contribution chart. Here you see two radiosensitive organs which are, for the majority of the cases, in our cone beam CT image. It concerns the thyroid and the salivary glands. Altogether, they contribute to almost half of the radiation dose obtained with cone beam CT. Salivary glands can't be excluded from the image yet. What could be interesting is to lift up the field of view of your cone beam as such to save radiation to the thyroid. And in this way, we are actually able to reduce radiation doses up to 20%, which can be very relevant for adults and surely for children. Cone beam CT is interesting in implant dentistry not only because it offers a diagnostic value in 3 dimensions, but also because it offers multiple other options related to the therapeutical approach, such as pre-surgical planning and integration of the implant placement, navigation tools, and CAD/CAM productions. And it are those different components that makes the cone beam being so popular in dental practice. What is important to consider when you talk about navigation, pre-surgical planning, and CAD/CAM is the fact that you also have to work with the jawbone model. And such model should have an accuracy which needs also to be checked. And in 2012, Van den Berge et al. Published a paper where he compared the model accuracy of cone beam CT and multi-slice CT. We did it by using a gold standard micro CT, as it has an accuracy below 10 micrometers. And by proper registration, we put all the cone beam CT and CT models on top of this micro CT. And then, using a color scale, we determined the differences, with red being overestimation expressed in millimeters and blue being underestimation. The latter means that when you properly register a CT or a cone beam CT on top of the micro CT anatomical model, you have actually a quite good results with a lot of green areas, meaning that this is situated around the 0 point, with most cone beams having errors in the 500 micrometer range and some even in the 200 micrometer range. This is another graph illustrating what we mean. Here you see actually the red bars representing the scoring and the accuracy of the models in the 2 millimeter error range. And then you see that for the various machines tested, both for the lower jaw and the upper jaw, you can obtain 100% accuracy with all machines. Yet, if going to the green bars, presenting a 500 micrometer accuracy, you will see that there is quite some variability in performance of various machines and various parameter settings. And usually it is stated that high resolution protocols within one machine or high resolution protocols from specific machines give a lot of diagnostic valuable information, but unfortunately also more noise and thus less quality models. Fortunately, most cone beams that are available on the market today offer the possibility to make models with an accuracy up to 200 micrometers, as such that you can use a separate jaws as a kind of diagnostic vertebral cast. This has also been checked by Al-Rawi et al. In 2010 at the occlusal level, where we also achieved a 200 micrometer accuracy when comparing the cone beam CT occlusal level with the macro CT occlusal level of a tooth. For sure, when talking about restorative work, it's evident that we will need a higher resolution than 200 micrometers. And for that we can integrate the information obtained with digital impression devices with the information obtained with cone beam scan, as such to make one integrated model of a 200 micrometers accuracy with at the level of the occlusal plane having a 20 micrometer accuracy. Interesting to notice in this accuracy chart of different impression machines is also that the scanners used to actually do surface scanning of dental casts are not better than the cone beam models. They have a similar error range, and thus the cone beam CT could be used as a vertebral cast. One more important point to consider why cone beam CT could be justified in implant dentistry is the fact that we also deal with anatomy and vital neurovascular structures. If, for example, we take this patient, we see that he is in need for posterior implant placement, and thus we need to identify the mandibular canal as well as the mental foramina. As you can properly locate them in the premolar radio, you may be surprised that when looking to the 3D image, there is actually a double mental foramen at both sides. It means also a double exit of a nervous bundle, which should be considered. Once knowing that, you can of course look back, but initially a majority of clinicians would probably not identify it on the 2D image. And this variant is occurring in about 8% of the cases. Another issue which may have been overlooked is the position of a salivary gland stone. This stone was present at the lingual ramus site, and it could be detected at the same time that the scan was taken for planning the implant surgery and for identifying the mental foramina. Another example where you can discuss the issue and use of cone beam CT is the present one. This patient got a fracture, the tooth was splinted, and afterwards an implant placement was planned. But when the implant was placed, the patient had a real neuropathic complaint. And so action was taken and a cone beam was made afterwards to check the real problem. Now, if you compare initial 3D images, which has seemingly been ignored during the surgery, you can clearly see that this implant in this patient has been placed right on top of what we call the lingual canal. The lingual canal is a midline neurovascular structure which contains neurosensory vessels as well as arterial blood vessels. And thus, when an implant is placed on that, either an indirect trauma by hematoma formation or a direct trauma to the nerve may occur. In this case, we have actually thus removed the implant in the first few days after the surgery to then allow placement of a smaller implant, and the problems disappeared. The placement of implants in the anterior mandible has been for a long time a debate, yet the presence of a complex neurovascular network and a high variability amongst patients, as you can see here, the midline area in different patients almost fingerprinting the patient, with the presence of a true neurosensory bundle together with arterial blood vessels in those canal contents, makes it very relevant to, even in this area, use a cone beam CT and avoid traumas as those shown before. Another area where the use of cone beam CT may be relevant may be the upper maxillary front, as in that area we are often challenged by the placement of an implant after a traumatic loss of a tooth. Now, in that area, we have normally the nasopalatine canal situated, which has a content with neurosensory fibers. Sometimes the canal is enlarged by trauma to the front. Sometimes the canal is also fused with an apical lesion of a tooth that has been traumatized, as is shown here. Thus, such fused lesions may really hamper implant placement, and the use of 3D imaging is essential to avoid any inferior treatment outcome. The same is shown in this result. This patient received implant placement in the upper jaw, but suffered pain after implant placement for several years. When he consulted, we saw that the implant had been placed in the neurovascular bundle of the nasopalatine canal, thus causing the irritation to both the blood vessels and the nerve. Sometimes this neurovascular bundle is removed to allow implant placement in that area, but other reports indicate some neurosensory disturbances in specific patients. From the present lesson, we can conclude that the sedentary guidelines are there for justified use of CBCT. You can find them on the internet by typing radiation protection 172. Furthermore, the EAO and the AAOMR have specific guidelines related to implant dentistry. In any case, cone beam CT is justified in implant dentistry to minimize the risks for neurovascular trauma, meanwhile maximizing the use of integrated 3D information for pre-surgical planning. I thank you for your attention.